DOLA patient-ready orthotics. The orthotics podiatrists use. A collection of our 9 most popular and proven prescriptions developed from over 50 years of clinical and orthotic experience. Patient-specific styles, ready to fit in clinic, orthotics for health professionals only. The Pronation patient-ready orthotic provides the medial support the pronated or flat foot needs. This video will help you identify which of your patients will benefit from adding the Pronation orthotic to their treatment plan. What type of foot will it help? What does it look like and how does it function? What conditions will it help? And why will this patient-ready orthotic help your patients? The pronated foot is a common presentation associated with many tissue stress pathologies of the foot and lower limb. From the posterior view, this foot may present with the calcaneus trending from a vertical to an everted position in the frontal plane, more concave malleolar curves, and the toes visible more laterally. From the medial view, the foot may present with a lower medial longitudinal arch, with the talar head palpable more medially than laterally. From the medial oblique view, the talonavicular region may appear more prominent, otherwise known as a talonavicular bulge. Using plantar pressure analysis, this foot may present with an increased plantar surface contact area and high focal or local pressures, often at the second metatarsal, metatarsals 2 to 4, or the medial and distal hallux. The foot may present with a primary ankle equinus, with proximal and distal compensations at the knee, hip, subtalar joint, and midtarsal joint. On assessment, there is a reduced non-weight-bearing ankle range of motion and reduced weight-bearing ankle function. A sagittal plane block at the ankle, or an ankle equinus, is a decreased ankle range of motion due to tightening of the posterior structures, including the gastroc or soleus. The foot may present with pathomechanical function beyond its tissue capacity, including functioning at or near end range of motion of rearfoot eversion from heel strike into midstance, or prolonged midstance pronation with lack of resupination into propulsion. This can lead to an impaired propulsion phase and poor windlass function. It can show signs of functional Hallux limitus, including avoidance of high gear toe off with a lateral or low gear toe off, or proximal compensations. On functional examination of the windlass mechanism with the Jack's test, results may include a reduced range of motion compared to non-weight bearing, high force needed for activation, or a delay in initiation. Local and proximal compensation combinations may include abduction of the leg with medial toe roll-off on propulsion, or adduction of the leg with a lateral toe off. Other common signs in gait may include forefoot instability, a prolonged midstance phase, and avoidance of the first MPJ high gear toe off. On examination, the forefoot of the pronated foot can present with several features. They include an abducted forefoot, Hallux limitus, a dorsiflex first ray, or functional Hallux limitus. A pronated foot can also present with many mistimed gait events. They can include heel lift, the previously mentioned prolonged midstance phase, or low gear and lateral toe off, and impaired propulsion and windlass mechanism. Your patient may present to your clinic with many pathologies relating to their foot posture and function, including various forefoot pathologies, including skin changes or hyperkeratosis, general metatarsalgia, metatarsal capsulitis, bursitis, neuritis, or neuroma, all relating to the impaired forefoot function in loading, but especially during propulsion or toe-off. First MPJ pathologies are also common, including bunions or HAV, and the development of Hallux limitus and sesamoiditis. These are all related to the foot loading, functional Hallux limitus, and forefoot instability. Toe deformities may also indicate impaired forefoot function, including plantar plate injury, claw toes, or retracted toes due to muscular imbalance. Common midfoot pathologies include plantar fascia or medial arch strain, sinus tarsi syndrome, mid-tarsal joint or Lisfranc injuries, cuboid syndrome, and midfoot osteoarthritis, all relating to the foot loading and increased tissue stress demands beyond tissue capacity. Common rearfoot pathologies include plantar fasciitis or plantar heel pain, heel spur, tarsal tunnel syndrome, fat pad syndrome, retrocalcaneal bursitis or Haglund's deformities, all relating to the foot loading and increased tissue stress demands beyond the tissue capacity. Posterior or anterior lower limb and ankle pathologies include Achilles pathologies, soleus and gastroc pathologies, flexor hallucis longus pathology, and anterior ankle impingement or extensor tendinopathies, all relating to sagittal plane function, foot loading, and the increased tissue stress demands beyond the tissue capacity. Medial lower limb and ankle pathologies can include medial tibial stress syndrome, shin splints, and tibialis posterior pathologies, all relating to the frontal plane function, foot loading, and increased tissue stress demands beyond the tissue capacity. Common lateral limb and ankle pathologies include lateral ankle instability and peroneal pathologies, relating to the frontal plane function, foot loading and instability, and increased tissue stress demands beyond the tissue capacity. Due to the proximal chain compensations previously mentioned, the patient may also present with common pathologies affecting the patella, patellofemoral joint, the knee, the sacroiliac joint, or the lower back. The signs may already be there in your current treatment program, giving you the confidence that the Pronation Orthotic will help your patient. Have you had success with taping, antipronatory taping, taping of the medial arch, lateral ankle, or forefoot? A footwear change to a more supportive style, a stretching or strengthening program, improved tissue capacity of the pathological tissue, or treatment-directed testing of a medial wedge, medial arch pad, or heel raise? Or has your patient had previous insoles? All of these may indicate that the patient-ready Pronation Orthotic will be a successful option. So how does the patient-ready Pronation Orthotic help my patient? This orthotic design provides the medial support the pronated or flat foot needs. Medial rear foot control. The rear foot platform provides the stability for transition from heel strike to mid-stance, with a medial wedge for increased medial orthotic force. The medial arch support provides support for the medial arch for transition from mid-stance to propulsion. It improves the windlass activation, improves forefoot stability, and promotes high gear toe-off. The lateral arch support stabilizes the foot and promotes the transition from heel strike to toe-off. The mild heel raise improves sagittal plane transition from mid-stance to propulsion and addresses any primary ankle Equinus. The full-length performance EVA shell provides the combination of cushioning and control needed by this foot, and the luxury DuraFit top cover is designed for both daily and sporting activities. For more options to fix the feet that walk into your clinic every day, see the full patient-ready range and be sure to check out the rest of the training modules. Need help finding the right orthotic for your patient? Use our online orthotic selector tool. Tell us about your patient, their activity level, pathology or lifestyle and performance goals, their foot type, clinical test results, and we will recommend the best patient-ready orthotic from our range. For daily education and training, follow us on social media, including Facebook and Instagram. Subscribe to our YouTube channel, follow us on LinkedIn, or visit dollarorthotics.com.